Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very handy in your line of duty. So I welcome you all to part 123 of our Pharmacotherapy MCQ series, which measures in infectious diseases. Welcome. And the first question reads, Mr. PZM, a 45-year-old male patient, was recently hospitalized at your university hospital with a past medical history of Child-Pugh B alcoholic liver cirrhosis. He was recently hospitalized for diverticulitis and was treated with ciprofloxacin and metronidazole. A week after the previous discharge, he was readmitted to your medical ICU. Some of his signs and symptoms are new fever, worsening abdominal pain for the past 72 hours, hypotension requiring vasopressor therapy. A CT scan was done and it showed or pointed to an intra-abdominal abscess. He was immediately taken to the operating room where an image-guided drainage was done and a culture was sent to the microbiology lab for further analysis. As empiric therapy, meropenem infused over 3 hours at a dose of 1 gram thrice daily was initiated. So my question to you is, which of the descriptions listed below most accurately describes PZM's clinical picture? Is this an uncomplicated community-acquired diverticulitis? Or is this a healthcare-associated infection? Or is this a high-risk community-acquired infection? Or is it D, a community-acquired infection of mild to moderate severity? I'll give you 10 seconds to choose the correct answer. Personally, I would consider this a healthcare-associated infection. Remember, this patient's recent hospitalization makes this case of healthcare-associated infection most probable. The other answers are incorrect. Let's move to the next question. And it reads, on day 2 of PZM's current admission to your medical ICU, the following lab results are uploaded by your clinical microbiologist onto the hospital intranet. So the image-guided drainage results, they have grown Candida glabrata. They've also grown Enterococcus faecium, Klebsiella pneumoniae, and Escherichia coli. Then the gram-positive rapid diagnostic panel shows Enterococcus faecium, which is a Van B/A, GID negative, and susceptibilities remain pending. Now, PZM is a febrile but still requires vasopressors. He's still hypotensive. So my question to you is, which of the following would be the next best course of action in the management of PZM's case? Would you choose to continue meropenem and add vancomycin and micafungin? Or would you continue meropenem and add vancomycin and fluconazole? Or Would you continue meropenem and add vancomycin, or would you continue meropenem monotherapy for at least 3 days prior to adjusting therapy? I'll give you 10 seconds to choose the correct answer. I would continue meropenem but add vancomycin and micafungin, and I'll tell you why. Now, the Enterococcus faecium, with no presence of either the VAN-B or VAN-A gene, indicates a vancomycin-sensitive strain. Therefore, vancomycin would be effective in its treatment. And the continued symptoms, despite broad-spectrum antibiotics, also necessitate the addition of an antifungal agent, preferably an echinocandin. Now, due to disease severity, micafungin and echinocandin is recommended. Let's move to the next question, please. PZM's Day 3 susceptibility results are uploaded by your clinical microbiologist on the intranet as follows. The image-guided drainage results included Candida glabrata, fluconazole, non-susceptible, Enterococcus faecium, vancomycin susceptible, Klebsiella pneumonia, resistant to meropenem, also resistant to imipenem, cilastatin, and ertapenem. Escherichia coli, pan-sensitive. PZM still remains or requires vasopressors. Still remains on vasopressors. Now, apart from discontinuing meropenem, which of the antibiotics listed below should be initiated immediately in PZM's regimen? So would you add ceftazidime, avibactam, and metronidazole? Or would you add ceftazidime, avibactam alone? Or would you add ceftolozane, tazobactam, and metronidazole? Or would you add ceftolozane, tazobactam alone? I'll give you 10 seconds to choose the correct answer. would add ceftazidime, avibactam, and metronidazole, and I'll tell you the reason why. Now, this patient is infected with a carbapenem-resistant enterobacteriaceae, what we abbreviate as CRE. And we know that ceftazidime, avibactam has reactivity or activity, against CRE organisms. And ceftazidime, avibactam does not have anaerobic activity. Thus, metronidazole should be added to it. Let's move to the next question, please. The next question reads, Mrs. OZP, a 47-year-old female patient, is admitted to your general medical ward with a history of 72-hour history of low-grade fever. She has a past medical history of alcoholic liver disease, a history of alcohol binge drinking to intoxication. Some of our pertinent labs include a WBC count of 12,000, a amylase is 700 units per liter, and the bili is 1.6 milligrams per deciliter. You establish she has no known drug or food allergies. The team does a CT of the abdomen, and on it they see a large pancreatic head with adjacent ill-defined peripancreatic inflammation, and there is fluid collection. And basing on that, a presumed diagnosis of acute pancreatitis is made by the team. So my question to you is, which of the regimens or interventions listed below would be the most appropriate for Mrs. OZP now? Would it be total parenteral nutrition to meet caloric requirements? Would it be fluconazole due to high risk of systemic candidiasis? Would it be supportive care with Ringer's lactate solution? Or would it be meropenem to prevent the development of necrotic pancreatitis? I'll give you 10 seconds to choose the correct answer. I would choose to offer this patient supportive care with lactated Ringer's solution, and I'll tell you why. Acute pancreatitis does not require antimicrobial therapy unless an extra pancreatic infection is also present, or the pancreas is necrotic. Now, neither is present in this particular case, and I would like to say that TPN is not warranted this early in the pancreatic process. So those many words justify why C, supportive care with lactated Ringer's solution, would be the best option. Let's move to the next question, please. And it reads, OZP was discharged home on recovering. She remained well, and then 90 days later, she was readmitted to the general medical ward. The signs and symptoms included worsening ascites, fever, and an altered mental status. The general surgeon performed an abdominal paracentesis, and the ascitic fluid results were as follows. The WBC count was 1,123 cells per mm cubed, and the percentage of segs was 53, percentage of lymphocytes was 11, the percentage of monocytes was 35, percentage of eosinophils was 1, and there was 0% basophils. Ascitic fluid and blood cultures are still pending. So my question to you is, which of the regimens listed below would be the most appropriate for OZP now? Would it be IV ceftriaxone at a dose of 2 grams infused over 30 minutes once daily for 10 days, but no secondary prophylaxis necessary? Or would it be the same dose of ceftriaxone daily for 5 days, but no secondary prophylaxis needed? Or would it be the same dose of ceftriaxone for 10 days, followed by secondary prophylaxis with levofloxacin indefinitely? Or would it be the same dose of ceftriaxone, 2 grams IV infused over half an hour for 5 days, followed by secondary prophylaxis with levofloxacin indefinitely? I'll give you 10 seconds to choose the correct answer. So I would choose to treat this patient with IV ceftriaxone 2 grams infused over 30 minutes once a day for 5 days, after which I would do secondary prophylaxis with levofloxacin indefinitely. I'd like to remind you that spontaneous bacterial peritonitis, abbreviated as SBP, requires antimicrobial therapy for 5 days, followed by secondary prophylaxis with a fluoroquinolone, while the patient remains at risk for SBP. That makes answer D the correct answer. Let's move to the next question, please. And it reads, Mr. MAO, a 76-year-old male patient, presented to your hospital with a past medical history of coronary artery disease. He is hospitalized due to urosepsis due to an MDR Pseudomonas species. Empiric therapy with cefepime was initiated on admission, and 8 days into his treatment, he developed profuse diarrhea lasting 48 hours, accompanied by increasing abdominal pain. Some of his vitals and labs include the fact that he's febrile, the WBC is 18,000, the serum creatinine is 1.1 at the moment. At baseline it was 0.8 milligrams per deciliter, and his blood pressure is 110 systolic and 90 diastolic. And you establish this patient has no known drug or food allergies, and your micro lab tests the unformed stool without paying attention to the electronic health record with regard to MAO's characteristics from the submitted specimens. So my question to you is, which of the diagnostic stool tests listed below would you consider ordering for MAO? Would it be stool toxin A or B, EIA test followed by stool toxin B nucleic acid amplification tests, or would it be stool GDH test followed by stool toxin B NAAT test, or would it be stool toxin A or B EIA test only, or would it be stool toxin B NAAT test only? I'll give you 10 seconds to choose the correct test. B it is, a stool GDH test followed by a stool toxin B NAAT test. Now the 2017 IDSA Share Clostridioides difficile guidelines suggest a two-step method unless laboratory personnel can verify that stool specimens are only received from patients with new onset and unexplained diarrhea, that is unformed stool, in 24 hours. As this is not the case with this particular patient, a two-step test that first starts with the GDH followed by the presence of toxins is recommended, and that makes B the correct answer in this particular case. Let's move to the next question. The gastroenterology resident on duty seeks your guidance as the clinical pharmacy specialist in the infectious diseases team on the best regimen for the patient above, Mr. MAO. So my question to you is, which of the regimens listed below would you recommend to this resident? Would it be fidaxomicin at a dose of 250 milligrams orally twice daily? Or would it be vancomycin at a dose of 125 milligrams orally as a suspension every 6 hours? Or would it be 500 milligrams of vancomycin suspension orally 4 times daily plus metronidazole infused at a dose of 500 milligrams thrice daily? Or would you settle for oral metronidazole at a dose of 500 milligrams administered orally 4 times daily? I'll give you 10 seconds to choose the correct regimen. I would treat with vancomycin suspension 125 milligrams administered every 6 hours. Now the 2017 IDSA SHEA guidelines recommend either vancomycin or fidaxomicin monotherapy as preferred first-line therapy regardless of disease severity. Now, if you look at the fidaxomicin dose, it's 250 and not 200, so that makes it incorrect. That makes answer A incorrect and leaves us with B as the correct answer. Do you know that for this case we require 125 and not 500 milligrams of vancomycin? And at this stage, you do not need to co-administer metronidazole and vancomycin. So that leaves you with B, vancomycin 125 milligrams QID orally as the best choice. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this brief video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it, to share it widely with your peers, and to leave your comments at the very bottom of it. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration, and I look forward to interacting with you all in subsequent videos. Thank you.